Imagine going to the doctor with a drooping eyelid, and after just one quick look at your face, they tell you to get an x-ray of your lungs.
Right. I mean, it sounds completely crazy. You go in for a minor cosmetic annoyance, and suddenly you're being screened for a tumor deep in your chest.
Exactly. But, in the hidden architectural language of the human body, that leap actually makes perfect logical sense. Welcome to today's deep dive.
Yeah, whether you're cramming for an anatomy exam or you're just like insanely curious about what is actually happening when doctors use those terrifyingly long Latin and Greek words, you're definitely in the right place today.
For sure. Our mission today, looking through our stack of sources, is to give you a shortcut to decoding some of the most intimidating medical jargon out there. It's going to completely change how you hear medical diagnoses.
We are diving into three of the most productive suffixes in the entire medical vocabulary. We're looking at dash cele, dash ptosis, and dash lith.
And what unites these three tiny word endings is that they don't describe a viral infection, right?
No, not at all. And they don't describe a hormonal imbalance either. They describe a fundamental structural problem. I mean, it's a failure of containment or support. Something in your body has pushed out, fallen down, or crystallized.
Okay, let's unpack this. Think of the human body as a house. Today, we are not looking at the house's electrical grid, because that would be your nervous system.
Right.
And we aren't looking at the thermostat or the invisible Wi-Fi signals, that's your endocrine system. We're looking at the literal, physical architecture.
Yeah, we are talking about the drywall bulging outward or the ceiling joists sagging under the weight of gravity.
Or the plumbing suddenly manufacturing its own gravel.
Hmm.
Because that is what cele, ptosis, and lith actually map to in the body.
But before we inspect the specific rooms of this house that are failing, we really need to look at who originally drew up these blueprints.
Right, because these suffixes weren't just generated by some committee in a modern hospital.
No, they're ancient Greek words. They were absorbed wholesale into Greco-Roman medicine thousands of years ago. I mean, if you look at the Hippocratic corpus from the 5th and 4th century BCE, physicians were already using the word cele to describe groin swellings.
Wow, that long ago.
Yeah, and a few centuries later, Galen of Pergamon, who was incredibly influential in systematizing early anatomy, he was using ptosis to describe organs prolapsing or falling down, and he used lithos to describe bladder stones.
Wait, so an ancient Greek physician could physically see a patient passing a bladder stone.
Yeah.
But without modern chemistry or imaging, how did they explain what that gravel actually was?
Well, they relied entirely on the humoral theory. This was the prevailing medical philosophy for centuries, the belief that human health was driven by a delicate balance of four bodily fluids or humors.
The blood, phlegm, yellow bile, and black bile.
Exactly. So if you developed a stone, a doctor in antiquity wouldn't think in terms of calcification. They believed your humors had literally congealed or baked together from an excess of internal heat.
I mean, it makes sense given the tools they had. They are observing a physical rock, but they are filtering it through this philosophy of balanced fluids. So when did we finally get the instruction manual that explained what these structural failures actually were?
So the major shift toward modern precision happened in the 18th and 19th centuries. That was the era when European medicine started standardizing these ancient Greco-Latin forms into a strict, rule-governed vocabulary.
Okay.
And a brilliant example of this transition is the English chemist William Hyde Wollaston. In 1810, he analyzed urinary stones and identified cysteine as a distinct chemical component.
Oh, wow. So he proved that these weren't just baked humors.
Right. He proved they were specific, identifiable chemical crystals.
That completely turns lith from a vague label, meaning, you have a rock inside you, into a highly specific diagnostic tool. You take that ancient Greek root for stone, stitch it together with the Latin word for the kidney, and suddenly you have a precise chemical and structural diagnosis.
Exactly. Which leads us right into the first major architectural failure of our house.
The bulging drywall. Let's look at cele, the great escape, when things push out of their designated cavities.
So the suffix cele comes directly from that Greek word chole, meaning a tumor, hernia, rupture, or swelling. In modern terminology, it denotes tissue or fluid bulging out of its normal space.
Okay, but modern medicine has a very strict definition of what constitutes a true hernia, right? Which creates this fascinating linguistic tension with how we still use this ancient word.
Yes, absolutely.
Let me test a deduction here. In a true hernia, like an inguinal hernia, a piece of the intestine physically pushes through a weak spot in the abdominal wall. So going back to the house metaphor, a true hernia is like someone stepping heavily and their foot literally breaking through the floorboards.
That's a great way to picture it. There is a distinct hole, and a structure is poking through it.
But then we also have words like hydrocele, which is a collection of fluid around the testicle,
Hmm.
or a mucocele, which is just a mucus-filled cyst in the mouth. Those aren't feet breaking through floorboards. Those are just puddles forming on the floor.
Yeah, you've hit on the exact clinical contradiction there. Etymologically, based on the ancient Greek, a hydrocele is categorized alongside hernias because they both involve a swelling.
Right.
But clinically, as you pointed out, a hydrocele involves no organ pushing through a fascial defect. It's just a blocked, distended sac of fluid. Medicine never completely disciplined the term cell to mean just one or the other. It still covers that entire spectrum.
But then you have something like an omphalocele, which is unequivocally a foot through the floorboards scenario.
Oh, very much so. An omphalocele is a severe birth defect where abdominal organs, usually the intestines and sometimes the liver, protrude through the base of the umbilical cord.
Wow.
Yeah, during embryonic development, the abdominal wall simply fails to zip closed properly. In the US, this affects roughly 1 in every 4,000 to 5,000 live births. It's a critical surgical emergency because those protruding organs are exposed. They're covered only by this fragile, semi-transparent membrane.
Here's where it gets really interesting, specifically regarding how we actually prevent these structural defects from happening in the first place. Let's look at the meningocele.
Right, so a meningocele is a form of spina bifida. The protective membranes covering the spinal cord, which are called the meninges, push out through a gap in the developing vertebrae.
Okay, so a bulge in the spine.
Exactly. In a standard meningocele, the spinal cord stays put. But in its more severe cousin, myelomeningocele, the spinal cord itself protrudes out through that gap. And that results in profound, lasting neurological damage to the lower body.
Now, we know that in 1998, the FDA took a massive step by mandating the fortification of enriched grain products with folic acid.
Yes, they did.
They literally changed the recipe for the bread and pasta we all eat just to prevent these neural tube defects.
Yeah.
But how does that fortification actually stop a myelomeningocele from forming?
Well, it comes down to cellular construction materials. Folic acid is vitamin B9, and it is an absolute requirement for synthesizing DNA and driving rapid cell division. In the first few weeks of pregnancy, the embryo's neural tube, which becomes the brain and spine, has to physically fold and zip itself closed. If the maternal environment is deficient in B9, the embryo simply cannot generate new cells fast enough to complete that zipper.
So the structural gap just remains open.
Exactly. By adding folic acid to the food supply, we basically ensured that early embryos had the raw materials necessary to close the floorboards, so to speak. It resulted in a massive public health triumph, drastically reducing myelomeningocele rates nationwide.
That is incredible. Now, moving from embryonic development to everyday plumbing issues, the varicocele is another perfect example of how structural design directly impacts function.
Yeah, a varicocele is an abnormal dilation of the veins draining the testicle. It's essentially varicose veins in the scrotum. And the mechanics of why this happens are fascinating because it's an asymmetrical problem.
What do you mean?
Well, a varicocele is markedly more common on the left side of the body.
Oh, interesting. So if it is primarily happening on the left side, that tells us it's not a general weakness of the blood vessels. There must be a specific anatomical flaw in the left side plumbing that creates a backup.
That is precisely the issue. The left testicular vein has to travel up and merge with the left renal vein, and it hits it at a sharp right angle.
Okay, so a harsh turn.
Right. Imagine two fast-flowing rivers meeting at a hard 90-degree turn. It creates immense back pressure. The right testicular vein, by contrast, has a much easier path. It drains directly, at a smooth oblique angle, straight into the massive inferior vena cava.
So that structural bottleneck on the left side causes the blood to pool. And this isn't just a minor anatomical quirk, right?
Not at all.
Because the blood is pooling in the scrotum, it radiates heat. And testicles need to be cooler than core body temperature to produce sperm effectively. So that pooled blood acts like a space heater, raising the local temperature, which makes varicoceles a leading yet highly treatable cause of male infertility.
Yeah, it perfectly illustrates the cascade. I mean, a failure of structural containment in a vein leads directly to a failure of biological function.
Okay, so when we look at hernias and bulging veins, the underlying force is usually pressure, right? Fluid or tissue pushing outward against containment walls. But what happens when the issue isn't pressure pushing out, but the internal anchors simply failing against gravity?
That brings us to ptosis, the great sag.
Right.
The suffix ptosis comes from the Greek ptosis, meaning a falling. It denotes a drooping or downward displacement of a structure that has lost its supporting hardware.
And this started with the eyes, didn't it?
Yeah, in early medical texts, it began as an ophthalmological term for a drooping eyelid, which is formally called blepharoptosis. But by the 20th century, doctors were appending it to everything. A stomach hanging too low was gastroptosis, a sagging abdomen was visceroptosis.
But the eyelid definition is the one that really stuck in the modern diagnostic toolkit. And what makes it so vital is that ptosis is a sign, not a disease itself.
Exactly.
The eyelid droops because something else up the chain is broken.
Right, a drooping eyelid is the ultimate red flag. I mean, it might just be an age-related stretching of a tendon, sure, but it can also be the first visible symptom of a major systemic crisis.
Like what?
Take myasthenia gravis, for instance. This is an autoimmune disease where the body produces antibodies that maliciously attack the receptors where nerve endings connect to muscles.
Ouch.
Yeah. And because the tiny muscles controlling the eyelid are constantly in use and have very little reserve strength, they fatigue rapidly. The ptosis is often the very first thing a doctor notices. It acts as an early warning system before the autoimmune attack compromises more dangerous muscles, like the ones used for breathing.
Which brings us back to that wild scenario we started the deep dive with. The eyelid dropping is a warning sign for a lung tumor. Let's break down the mechanics of Horner syndrome.
Yes. So Horner syndrome is a diagnostic triad. A patient presents with ptosis, which is the drooping eyelid, meiosis, which is an abnormally constricted pupil, and anhidrosis, which is a total lack of sweating on that side of the face.
It's on one side.
Right. And this triad occurs when there is a disruption anywhere along the sympathetic nerve chain.
And just to clarify for you listening, the sympathetic nerve chain is our fight-or-flight highway. When a threat appears, that nerve chain sends signals to dilate your pupils so you can let in more light and see the predator.
Exactly.
It opens your airways, and it triggers sweating so you don't overheat while running away.
So if you sever or compress that specific nerve highway, those functions drop offline. The pupil can't dilate, so it stays constricted. The sweat glands shut down, and the subtle muscle holding the eyelid wide open goes limp, causing the ptosis.
Okay, but how does that connect to the lungs?
Well, this nerve chain runs all the way from the brainstem down through the neck, and it loops to the upper chest before heading back up to the face.
Oh, wow. So if the highway stretches down into the chest, a roadblock anywhere along that route will shut down the eye.
Exactly. That roadblock could be a carotid artery dissection in the neck.
Which is a tear in the artery, right?
Yeah, a severe tear in the inner lining of the artery wall. It allows blood to pool and create a false pouch that presses outward against the nearby nerve chain. Or, even more surprisingly, the roadblock could be a tumor growing at the very apex of the lung.
Ah, there it is.
Yeah, as the lung tumor expands upward, it crushes that sympathetic nerve chain right against the ribs.
A symptom isolated entirely in the eye, caused by a structural failure deep inside the chest cavity. It is an incredible piece of diagnostic logic, though I have to point out a much more common self-inflicted version of this mechanism we see today, which is Botox.
Oh, right.
People inject a neurotoxin into their forehead to freeze their wrinkles, but if that liquid migrates even a few millimeters, it blocks the nerve receptors of the eyelid muscle. The structural support is knocked offline, giving the patient a temporary cosmetic ptosis.
It's the exact same physiological failure. I mean, a disruption of nerve signaling causing structural collapse. It's just applied in a modern aesthetic clinic.
We've covered the drywall bulging outward under pressure with cele and the ceiling falling down due to gravity with ptosis. Now we pivot to the final structural failure, the body accidentally manufacturing its own internal debris. Let's talk about lith.
So the suffix lith stems from the Greek lithos, meaning stone. And while our understanding of the precise chemistry has advanced since Wollaston in 1810, the core concept remains remarkably stable. It's a solid mineral deposit forming where it shouldn't.
And the sheer volume of people affected by this is staggering. The U.S. health data for nephrolithiasis, which is kidney stones, shows a lifetime risk of roughly 1 in 11 Americans.
It's extremely common.
Yeah, and we typically hear about calcium oxalate stones, but you also see uric acid stones, which correlate with diets high in purines like red meat, and struvite stones, which only form when specific bacteria cause a urinary tract infection, fundamentally altering the pH of the urine.
But what's fascinating here is that beyond diet and infection, studying these stones gives us a profound window into human genetics and metabolic evolution. Look at choledocholithiasis, or gallstones. Starting in the 1960s, epidemiologists noticed that the Pima populations of Arizona had extraordinarily high rates of gallstone disease. I mean, some of the highest figures ever documented globally.
And this wasn't an environmental fluke, right? This was directly tied to something called the thrifty gene metabolic profile.
Yes, exactly. For generations, the Pima populations adapted to desert environments where food was often scarce. Their bodies evolved to be hyper-efficient at storing calories.
Makes sense.
However, when you introduce a modern Western diet to that specific metabolic profile, the system goes into overdrive. The liver begins dumping massive amounts of excess cholesterol into the bile.
Oh, wow.
Yeah, the bile becomes so supersaturated that the cholesterol physically crystallizes, forming stones in the gallbladder. It's a powerful example of how a microscopic metabolic shift cascades into a tangible, macroscopic rock.
While we are looking at gallstones and kidney stones, we really should bust a couple of common myths. The first instinct when hearing kidney stone is to picture someone screaming in the emergency room.
Right. The pain.
But the truth is, a massive number of these stones are entirely silent. They just sit in the kidney or gallbladder and are only discovered incidentally when a doctor orders an X-ray or an ultrasound for a completely unrelated issue. The agonizing pain only triggers when that stone decides to move and physically obstructs a narrow duct, causing fluid pressure to rapidly build up behind it.
Right. That obstruction is what triggers the severe inflammatory and pain response. And, another structural misunderstanding involves tonsil stones or tonsilloliths.
Yes, people see these little white calcified chunks in the back of their throat and panic. They assume they have a severe bacterial infection or terrible dental hygiene.
But tonsilloliths are mostly just normal cellular debris. The tonsils are filled with natural crevices and pockets. Dead skin cells, mucus, and harmless oral bacteria just get swept into these pockets.
And for people who naturally have deeper tonsillar crevices, this debris gets trapped, compresses, and slowly calcifies into a small stone.
Exactly. It is a structural nuisance, not a sign of underlying disease.
So having mapped out the architectural failures, the bulges, the sags, and the stones, what is the medical playbook for fixing the house?
Well, knowing your suffixes actually gives you a cheat code for understanding surgical interventions. If a patient presents with a ptosis, a sagging organ, the surgeon's goal is fixation. They perform a pexy.
Okay.
For instance, suturing a drooping kidney back into place is a nephropexy.
And if the issue is a cele, a gap, or a bulge, the fix is usually a regraphy, which means suturing, or a plasty, meaning surgical reshaping. So a hernia repair is a herniography.
Right.
And for the stones, the liths, the definitive solution is often an echography, the surgical removal of the entire organ that houses the stones, like a cholecystectomy removing the gallbladder.
Exactly.
But, just because we have a surgical hammer doesn't mean every structural quirk is a nail. The history of medicine is loaded with cautionary tales where doctors saw a slight architectural variation and aggressively operated when they should have just left well enough alone.
Yeah, if we connect this to the bigger picture, the most glaring historical example is the floating kidney fad.
Oh, this one is wild.
When a person stands upright, the kidneys naturally descend a few centimeters because they are suspended in fat and connective tissue. They aren't bolted to the spine. In the late 19th and early 20th centuries, some physicians decided this normal mobility, which they dubbed nephroptosis, was a pathological disease causing vague abdominal complaints, particularly in women.
And American surgeons like George Oedipus built entire careers out of aggressively performing nephropexy surgeries. They were literally cutting patients open to anchor a perfectly healthy, normally functioning kidney.
Yeah. And it took decades of tracking surgical outcomes for the medical establishment to admit that without an actual blockage or functional decline, a slightly mobile kidney is harmless. It is a stark reminder that structural variation does not automatically equal disease.
And we don't have to look back 100 years to see that exact same mistake. We watched it happen in modern gynecology with transvaginal mesh.
We really did.
In the early 2000s, it became standard practice to use surgical mesh to treat pelvic organ prolapse, specifically cystoceles, where the bladder bulges into the vaginal wall, and rectoceles, where the rectum bulges. Doctors saw a structural sag, a cele, and they assumed the best fix was to staple up synthetic floorboards.
But the intention was to provide support, and instead, the synthetic mesh created massive cascading complications.
Right.
The surrounding tissues reacted poorly, reports flooded in of chronic debilitating pain, the mesh eroding through the vaginal wall, and even perforating surrounding organs. The FDA issued safety warnings in 2008, updated them in 2011, and finally, in 2019, completely banned the sale of transvaginal mesh for pelvic organ prolapse in the United States.
It is the exact same lesson as the floating kidney. Just because you have the technology to diagnose a sag or a bulge doesn't mean the invasive structural fix won't end up damaging the house more than the sagging drywall ever did.
The true art of medicine is clinical judgment. It's knowing the difference between a benign architectural quirk that requires observation and a true structural failure that genuinely threatens the patient's well-being.
We've covered the entire architectural spectrum today. You now have the master key to decode almost any diagnostic term built from these roots. When you hear a word ending in cell, you know to look for what is bulging outward under pressure.
And when you hear ptosis, you know to ask what internal anchors failed against gravity.
And when you hear lith, you know a microscopic metabolic process has crystallized into a macroscopic rock.
So for you listening, what stands out to why you and him, how medicine evolved? I mean, we walked from ancient Greeks attributing a stone into congeal humors, all the way to understanding the exact cellular mechanics of folic acid closing a neural tube.
It really makes you wonder where the vocabulary goes next. We've seen how lith diagnoses evolve from humoral theories to precise chemistry. Right now, medical imaging and genetic testing are advancing at a blistering pace. 100 years from now, will future doctors look back at broad structural terms like cele and ptosis as terribly primitive?
Oh, that's a fascinating question.
Will they even use a suffix that just means, it fell down? Or will every structural failure be redefined by the exact microscopic cellular defect that caused the connective tissue to give way in the first place? Will the macroscopic X-ray of the broken house be entirely replaced by a molecular breakdown of the drywall?
I guess we'll have to wait and see.
Keep asking questions, keep unpacking the jargon, and stay curious. Until next time.